Yeah, okay, fine. So I'm going to start off by talking, as the slide shows here, about the management of an acute sickle cell crisis and focus on the clinical management. Next slide. So as you all know, sickle cell disease is a multi-system disease, and it's characterized by both acute episodes, which we'll be focusing on mainly in this talk, and also chronic organ damage. And clinical features are characterized by the acute pain episodes, what we sometimes or usually call crises, and chronic manifestations, including chronic pain and consequences of hemolytic anemia or hemolysis. There's also a significantly increased risk of infection, partly due to hyposplenism and progressive end organ damage. And despite better management and despite better treatments, sickle cell disease is still invariably associated with premature death compared to the average population. Next slide, please. So just before we go on to the clinical aspects, I just wanted to show this one slide reminding us of the kind of pathogenesis and mechanisms of how sickling occurs and how it leads to the vaso-occlusive crises. So the reason for the kind of vaso-occlusion manifestations of sickle cell disease is due to the properties of hemoglobin S or sickle hemoglobin, which polymerizes under deoxygenated conditions. And that causes distortion of the red cell shapes, leading to the classic rigid sickle cell shapes that we all know of. And these get obstructed as they flow through the microvasculature and stick to the vascular endothelium, causing vaso-occlusion and the crises, which we'll go on to talk about. The other consequence of hemoglobin S polymerization is that it causes hemolysis. And people with sickle cell disease invariably have kind of a chronic hemolytic anemia. And this leads to most of the chronic complications of sickle cell disease, or many of the chronic complications of sickle cell disease are due to chronic hemolysis. So we're not going to be talking as much about those, focusing more on the vaso-occlusion and the acute episodes. Next slide, please. I've just listed here some of the common types of crises. So dactylitis is due to crises occurring in the digits and the hands and the feet, mainly in children, causing swelling and pain. Sequestration crises, which we'll touch upon if we have time during toward the latter part of the talk. Hemolytic crises, aplastic crises, often due to parvo 19 infection, leading to a reduction in red cell production. And then the vaso-occlusive or pain crisis and acute chest syndrome, which are the ones that we're going to be focusing on predominantly in this talk, because they're the most common presentations that we tend to see in sickle cell patients, acute presentations, and acute chest syndrome is associated with significant mortality if it's not recognized and managed appropriately. Next slide, please. So I've just listed here some of the trigger factors for sickle cell crisis. Many of them are kind of well known to us. So infection, which we screen for and test for in patients when they present with crisis, dehydration, hypoxia, and hypoxia is important when patients are undergoing surgery, that they may be exposed to hypoxia due to the general anesthetic and need to be managed carefully around that time of the perioperative time. Women who kind of at a time when they're undergoing any kind of hormonal fluctuations, so around the time of their menstruation or during pregnancy, are at higher risk of crises. Exposure to cold environments, excessive physical exertion, stress, and excessive alcohol consumption. And in many cases, there's no obvious identifiable trigger. Next slide, please. So let's talk about pain, because that is a hallmark of acute presentations of sickle cell disease. A very large number of sickle cell patients do have chronic pain and live with daily pain, but what we're talking about here is a severe acute exacerbation of their pain during an acute sickle cell crisis. And there are various ways in which we assess and categorize their pain, various different types of pain scores. And commonly, one of the scores that is used is a 1 to 10 scale, on which less than 4 would be classified as mild pain, more than 6 would be classified as severe pain. And in other institutions, they tend to focus more on mild, moderate, and severe rather than use a 1 to 10 scale. Sickle cell pain, due to a sickle cell crisis, pain can last for hours to days, and it is a extremely severe and intense pain, and it has been described by women with sickle cell disease as being more severe than the pain they experience during labor, and it can be as intense as post-operative pain. Next slide, please. And here, some studies just to look at the frequency of pain in sickle cell patients, and some of the kind of terminology which patients use to describe their pain. So pain is present in up to 95% of hospital admissions due to sickle cell disease. About 30% of patients, adult patients, have some degree of pain 95% of the time, and only 14% of adult patients are in pain less than 5% of the time. And some of the adjectives which they've used to describe pain are unbearable, excruciating, stabbing, and other descriptions such as a pain that I wouldn't wish on my worst enemy, or like being hit by a truck and getting run over. So just to give you some kind of idea as to the severity of this pain. Next slide. So how do we assess the patients when they first present? So obviously the patients present with severe pain, but may also be unwell medically. So they should undergo a full comprehensive kind of ABCDE resuscitation type assessment to determine whether there are any concerning or red flag features, and they should be reviewed urgently by a senior member of the hematology team, a registrar, and any red flags indicating something more complicated than a painful crisis alone should be identified at that stage. Next slide, please. These are the baseline investigations which we recommend should be carried out in patients when they present with acute sickle crisis. So most of them are fairly self-explanatory. FBC reticulocyte count, which is often increased in most sickle cell crises apart from aplastic crisis. HBS level, because if the patient deteriorates and then subsequently a decision is made that the patient requires some form of transfusion, then it's very helpful to have a baseline HBS level on the patient, particularly if they're already on chronic transfusion therapy. Routine biochemistry tests, including inflammatory markers and hemolysis screen, and a group and save and cross match again in case they end up needing a transfusion. Next slide, please. So in terms of the initial management, so the patient should be, as we mentioned, thoroughly assessed, and their pain should be fully characterized. So all the questions that we're taught to ask about pain, such as the site of the pain, the severity of the pain, exacerbating and relieving factors of the pain, and often it's very, very helpful to ask the patients if there's anything unusual about the pain, because they will usually be very, very familiar with what sickle cell pain is like, and it's often helpful, I think, to ask whether this is typical of their sickle cell pain or whether there's something unusual or anything different to suggest an alternative pathology. So the patient should be given hydration, bearing in mind that in this group of patients, IV access is often quite challenging, and it may be not possible initially to secure IV access. Some patients may be able to maintain adequate oral hydration, but where that's not possible, then attempts should be made to secure IV access and give IV fluids. The patient should be kept warm, and if there is any concern about hypoxia, so saturations, oxygen saturations on pulse oximetry less than 95%, then they can be given supplemental oxygen via appropriate oxygen delivery system. And then obviously one of the most important aspects of managing these patients is to control their pain effectively. We've already talked about how severe this pain is, and therefore it warrants, treatment with very strong analgesia. Invariably, these patients will need strong opioid analgesia when they present. Most patients should have some form of individualized protocol which should be followed, and where there isn't an individualized protocol, then refer to local guidelines for kind of generic protocols of what opioids to use. Majority of patients in the adult setting will be given parenteral opioids. However, in the pediatric setting, many children are treated with oral opioids and possibly intranasal opioids as well. And a few of the adults are still on oral opioids, but the majority by far are on parenteral opioids, subcutaneous, and in some cases intravenous. There's also an option of treating patients with the PCA, patient-controlled analgesia, which is recommended by the NICE guidance as well, which we'll talk about subsequently. And there are recommendations that strong recommendations that pethidine should be avoided for treatment of acute sickle cell patients, unless there's absolutely no alternative due to the increased risk of giving pethidine in this situation. And whilst strong opioid analgesia is the mainstay of treatment of acute sickle cell crisis pain, we shouldn't forget to, alongside, prescribe the adjuvant painkillers, which can also be effective alongside the opioid analgesia. Paracetamol, particularly when it's given intravenously, can be very helpful for many patients, and non-steroidal anti-inflammatory drugs. Many patients will also be on some form of chronic gabapentinoid type of painkillers, or duloxetine for chronic pain, which should be continued as well. These patients are also at significantly high risk of venous thromboembolism, and that is due to a combination of different factors. That during an acute sickle cell crisis, there is a kind of a surge of inflammatory cytokines which are prothrombotic. Patients are often also immobile due to the severity of their pain, and often insufficiently hydrated. So all of these risk factors make them at high risk of thrombosis, and unless there's any contraindication, DVT prophylaxis, thromboprophylaxis is extremely important in this group of patients. Folic acid they should be on normally, and that should be continued. And then incentive spirometry. So there are studies which show that one of the interventions that actually does improve outcomes in patients when they present with sickle crisis is incentive spirometry, and all patients should be given that and offered that. And it has been shown to reduce the incidence of respiratory complications in these patients. And then we should be, after treating them with analgesia, we should be reviewing the patients regularly to monitor the efficacy of the intervention by going back and reassessing the pain score, and also monitoring for any side effects of the intervention. So looking for any opioid toxicity effects such as sedation or respiratory complications of opioids. Next slide, please. If there is any signs or suggestions of sepsis, such as pyrexia or raised inflammatory markers on the blood tests, then a full septic screen should be undertaken, and the patient should be started on broad spectrum antibiotics to cover community acquired infections. In our trust, the first line recommendations would be ceftriaxone and clarithromycin, but obviously there would be some variation between different centres. And part of the septic screen would include blood cultures, urine, sputum samples, and chest X-ray. Next slide, please. Sorry, just going back to the last slide. So I had put on the regular monitoring of the oxygen saturations, and I just wanted to highlight just one point about that is in order to pick up or identify a situation where a patient could be deteriorating, developing an acute chest syndrome, for instance, or have some other pulmonary pathology going on, it's extremely important to ensure that the oxygen saturations are monitored are measured on room air. If the patient has been put on oxygen and if the saturations is only measured when they're on the oxygen, then we may be missing the fact that the patient has a respiratory associated respiratory complication. Next slide, please. So just coming back now to the NICE guidance on managing an acute pain episode. This is quite old and in need of updating now. But, it was published in 2012 with an update in 2014. Next slide, please. And I'm just going to highlight the main kind of points that were recommended in the NICE guidance. It's quite a long document, but essentially what they recommended is an individualized assessment is done for each patient, so patients are not all treated the same. And that they're offered analgesia within 30 minutes of presentation. And this has now become the gold standard recommendation for patients when they present with sickle pain nationally, that the target is, and the benchmark is that they should be receiving the first dose of analgesia during that period of 30 minutes. And then obviously the vital signs should be checked and monitored regularly. Next slide, please, Ralph. In terms of analgesia, as mentioned previously, the NICE guidance also stresses avoidance of pethidine as the analgesia, unless there's no other alternative. And the guidance is quite old, as mentioned, and does recommend diamorphine as a first line opioid of choice. However, in recent years, there have been inconsistencies and shortages of supplies of diamorphine. So many centres now, including ours, have changed to morphine as being the kind of first line default opioid of choice. And it was also noted in the NICE guidance that many children are on oral opioids. The importance of the individual protocols was highlighted. And now with the UCPs, we have access to protocols, London-wide, so we can review protocols of patients who may be under the care of other centres in London. And PCAs were encouraged by the NICE guidance as a way of achieving effective pain control. The importance of the adjuvants, as mentioned previously, was highlighted, and it was also highlighted that there can be a huge variation in response to opioids between patients, and that can be due to factors such as the body weight of patients, whether they're on long-term opioids at home and therefore have a degree of tolerance and therefore require larger doses of opioids when they come into hospital. So all of these factors should be taken into account when we decide on what doses we are prescribing for individual patients. Next slide, please. And then the other very important aspect of the NICE guidance is the importance of continuing to reassess patients, not just treating them with analgesia and then thinking that that's the end of what you need to do, but going back and continually reassessing how effective the analgesia has been. So really every 30 minutes they need an assessment until achieving satisfactory pain relief, and thereafter still regular assessments approximately every 4 hours to continue to assess whether their pain is being adequately controlled. Again, the importance of using a age-appropriate pain scoring tool was highlighted. So, for instance, in children, often the pain scoring tool is used is the kind of this emojis, smiley faces or sad faces. In adults, as mentioned, 1 to 10 verbal pain rating score or mild, moderate to severe rating. And we can also assess the efficacy of the painkillers by asking questions such as, how well did that last painkiller work? Do you feel that you need more pain relief? Next slide. And I think this is the last slide regarding the NICE guidance. So they also highlighted the importance, as I've alluded to earlier, of monitoring the patients regularly after giving them strong opioid analgesia, to assess the efficacy, as we've already mentioned, but also to assess for any complications of opioids. So any evidence of drowsiness, sedation, respiratory depression, other complications. Next slide. Just to highlight that in our trust, we do have some some other aspects of or some other suggested aspects of the management that we advise. So in our trust, we don't give IV opioids, although they may be used in other trusts. We give parenteral opioids subcutaneously, and we don't use IV cyclazine. Where antiemetics are required, cyclazine is used orally, or other antiemetics such as ondansetron are used. And I think this is now fairly universally adopted across specialist haemoglobinopathy trusts that IV cyclazine is not recommended. And just a reminder to prescribe the adjuvants and VTE prophylaxis unless there's a contraindication. The respiratory status of these patients should be carefully monitored to detect any or to identify any sign that they may be developing acute chest syndrome. If there's any hypoxia, if there's any low readings on the pulse oximetry, then they should have an ABG performed, and a chest X-ray if there's any chest pain or other respiratory symptoms. The ABG is often an important parameter. The PO2 on the ABG is often a very important parameter in determining what further interventions might be required if a patient is deteriorating and thought to be developing an acute chest syndrome. In a lot of sickle cell patients, pulse oximetry alone is often not a very accurate marker of oxygenation and can give false readings. At the bottom there, I've just put a just to show that we have a comprehensive sickle cell guideline that is available on our trust internet that we would refer to, and that contains a detailed section on the management of an acute sickle cell crisis and acute sickle cell complications. Next slide, please. So this slide just highlights the kind of presenting features which should raise the concern that the patient is much more acutely unwell and needs much more rapid review and intervention. Most of these are fairly self-explanatory and would raise alarm bells. So if a patient came in with septic shock and was hypotensive, any acute neurological signs or symptoms, hopefully in that case they would present to a neurological unit or an acute stroke unit rather than to a hematology or ED unit if that was the case. If they had significant hypoxia and a significant drop in hemoglobin from their baseline, and acute fulminant priapism, particularly any episodes lasting more than 4 hours, would need urgent action as well. And apart from those, the ones listed at the bottom, so extreme pain out of keeping with what a patient normally experiences during a sickle cell crisis, any signs of infection or sepsis, and any respiratory or abdominal signs or symptoms, and any evidence of acute hepatic or splenic enlargement suggesting sequestration syndrome. Next slide, please. Just to summarize then what was on the previous slide, so just really important to identify those red flags suggesting that the patient is deteriorating or presenting with a much more kind of medically severe complication of sickle cell disease. And some of those red flags include hypoxia, fever, tachycardia, and falling hemoglobin level. And these patients warrant immediate senior review and discussion with a consultant and early liaison with the ITU team or the critical care outreach team. Next slide. Okay, this slide is just highlighting some of the common problems that are encountered in managing patients with acute presentations with sickle cell disease. Often these patients face unacceptable delays in receiving their analgesia, hence, the national standard and the target of 30 minutes to receive the first dose of analgesia. But despite that, many times, particularly in busy ED departments, patients don't receive the analgesia within the desired time frame. Occasionally, patients may receive insufficient doses of opioids or do not get opioid doses as a follow-up doses of opioids. And on the converse, some patients may be given excessive opioid doses and then lead to complications and opioid toxicity problems. They may be given the wrong type of analgesia, and unfortunately, it's not uncommon that patients are stigmatized as being drug seeking when they're seen, particularly in some of the ED departments, where the staff are not as don't have so much experience in seeing and managing patients with sickle cell disease. Next slide. So I'm going to now move on to talking about acute chest syndrome, which, as I mentioned earlier, is a complication which is extremely important to recognize and to manage because it is a common cause of mortality in patients with sickle cell disease. So it can be quite difficult to distinguish. So acute chest syndrome essentially refers to where there is sickling in the pulmonary vasculature. And it's important to distinguish between chest pain and acute chest syndrome, because sometimes patients come in with acute chest pain due to sickling in the ribs or in the sternum, and they may call that having a chest syndrome or having a chest crisis. But acute chest syndrome actually refers to pulmonary sickling in the pulmonary vasculature. It can be quite difficult to distinguish between an acute chest syndrome and a pneumonia or lower respiratory tract infection. But usually patients with acute chest syndrome are more sick and have a more significant degree of respiratory compromise. Acute chest syndrome, by and large, occurs in the context of a pain crisis as well. So patients will usually come in with severe pain and in addition have the respiratory manifestations as well. Invariably, they will have raised inflammatory markers and usually fever. And then, as I mentioned, respiratory manifestations of hypoxia, tachypnea, and tachycardia. And on the chest X-ray, one of the things that can be useful in distinguishing it between a lower respiratory infection is that the infiltrates on the chest X-ray and indeed the clinical signs on examining the patient are often bilateral and bibasal. However, the radiological signs may lag behind the clinical presentation, so it's important that we don't rely on a radiological diagnosis and that we use the clinical features to determine whether the patient may be having an acute chest syndrome. Next slide, please. There is a BSH guideline, again quite old, regarding the management of acute chest syndrome in patients with sickle cell disease. And they defined in that guideline, acute chest syndrome is defined as an acute illness characterized by fever and or respiratory symptoms accompanied by a new pulmonary infiltrate on the chest X-ray. So it's quite interesting that hypoxia is not a definition in that guideline of acute chest syndrome. However, I think that's probably something which I would say is probably needs to be reviewed, because in practice, I think hypoxia would be one of the first indications that the patient may be developing an acute chest syndrome. Next slide, please. And it's important to stress that acute chest syndrome can either occur at the time of presentation, so the patient can present with an acute chest syndrome, or it can occur later on during the admission. So if they could be admitted with what was felt to be an uncomplicated pain crisis at the time of admission, and then go on to become hypoxic and develop acute chest syndrome. So that highlights the importance that patients, once they're admitted, need to be constantly reviewed and assessed for any further complications, particularly respiratory complications. And acute chest syndrome can be triggered by PE, fluid overload, opioid toxicity, hypoventilation. Predictors of severity include worsening hypoxia, increased respiratory rate, reduced platelet count, dropping hemoglobin, multi-lobar involvement on the chest X-ray, and neurological complications. Next slide. This is just to show the X-ray changes. So this is a patient when they first presented, on the left, having a normal, reasonably normal looking X-ray, and then a couple of days later, well, 4 days later, developed this very florid, abnormal X-ray with bilateral pulmonary infiltrates. And that just highlights that the fact that the X-ray radiological changes can lag behind the clinical presentation. Aside from acute chest syndrome, it's just important that we bear in mind that there are other causes of hypoxia in patients with sickle cell disease, as listed there. So I've already mentioned the differential diagnosis of acute chest syndrome being lower respiratory infection, pulmonary embolus, opioid toxicity, fat embolism syndrome, and pulmonary hypertension, which often leads to a kind of more chronic type 2 respiratory failure picture. Next slide, please. We'll skip over that one. Yeah, so in terms of managing acute chest syndrome, in terms of the early stages of acute chest syndrome, or the milder stages of acute chest syndrome, the patients can be managed with NIV. And previously, we used to generally advise that these patients are treated with CPAP. But often now, when they're transferred to HD or ITU, they receive Optiflow rather than CPAP. And they may require a top-up transfusion. In more severe cases of acute chest syndrome, generally patients are treated with automated red cell exchange transfusion. Next slide. Just to talk a little bit about vascular access in sickle cell patients. Many sickle cell patients will have quite difficult and challenging IV access. Obviously, where possible, we would try peripheral vascular access, but where that's not possible, then we often have to consider alternative types of access, such as midlines or femoral lines, and possibly a central line if the patient is needing an acute red cell exchange and going to ITU. Sometimes they receive neck lines as well. So if the IV access is very challenging, we often get the anaesthetist involved to help us with cannulation and IV access. Next slide. Skip over that one. Yep. So just in the last few slides to talk about some of the other common emergencies in sickle cell disease. Neurological presentations, including stroke, acute priapism, sepsis, biliary complications, fat embolism syndrome, and hemolytic transfusion reactions or hyperhemolysis. And we'll just touch on one or two of these in subsequent slides. Next slide, please. So neurological presentations are common in sickle cell disease, particularly in children, and these can take the form of stroke, either thrombotic or hemorrhagic, thrombotic being more common in children, and hemorrhagic in adults due to development of cerebral vasculopathy due to sickle cell disease. Next slide. So this just highlights that stroke is very common in sickle cell disease. By the age of 20 years, 11% of patients with sickle cell disease, predominantly SS and S beta 0 thal genotypes, will have had a manifestation of a stroke. And hence, there is a national screening program to pick up patients at higher risk of strokes via the transcranial Doppler screening, and patients identified at high risk started on some form of transfusion program, for which there was evidence from the STOP clinical trial. Next slide. So I'm not going to go into this into too much detail, but generally patients presenting with acute neurological complications should be directed to an acute neurology unit, a stroke unit, and should be managed as per the stroke team advice initially. And then imaging should be performed, including imaging to look for evidence of sickle vasculopathy. Generally, these patients would be treated with an emergency red cell exchange. There is limited evidence regarding thrombolysis in patients with sickle cell disease. However, some patients may benefit, particularly patients who are, middle-aged age group, who have other kind of classical non-sickle related risk factors for stroke, may be the ones that benefit from thrombolysis, but it has to be discussed on an individual basis, because if these patients have cerebral vasculopathy or cerebral aneurysms, then thrombolysis may be quite risky in these patients. Next slide, please. Just a few words about splenic sequestration. So again, this can have a high mortality and results in acute drop in hemoglobin due to pooling, large volumes of blood pooling usually in the spleen, sometimes in the liver. Often it occurs in patients who have a milder sickle cell phenotype, who retain splenic tissue, and the patients can present very unwell with hypovolemic shock due to a rapid reduction in intravascular blood volume. They would generally be treated with a top-up transfusion. However, it's important not to over-transfuse these patients, because when the sequestration reverses, and the blood re-enters the circulation from the spleen, if the patient has been overtransfused, then the hemoglobin may rise significantly above their baseline, putting them at risk of hyperviscosity and neurological complications. Next slide, please. Fat embolism syndrome is an important thing to be aware of because, again, it has a very high mortality in sickle cell patients, and it is basically a situation where there's multi-organ involvement due to severe sickle cell crisis resulting from bone marrow necrosis and release of fat particles into the circulation. Patients can present with most commonly pulmonary, neurological, cardiac and renal involvement, and treatment should be directed via a specialized, a specialist sickle cell unit or specialist hemoglobinopathy center. And generally treatment would be to do an emergency red cell exchange followed by plasma exchange to remove the fat particles and the inflammatory cytokines which are released in this situation. The importance of that is really just to recognize it so that it can be directed to the appropriate specialist center and managed appropriately. Next slide. Skip over that one. And that one. Just to finish off, I just wanted to discuss two quick cases just to put what we've talked about all into context. So the first case is a 25-year-old female in the third trimester of her first pregnancy with a diagnosis of sickle beta thalassaemia and lupus nephropathy. She has known red cell alloimmunization with anti-S and anti-JKB, and the patient is admitted with worsening fatigue and shortness of breath for the past 2 days. On examination, the patient is pale but not jaundiced and has saturations of 99% on room air and is hypertensive. And the blood results come back showing a significant anemia and a drop from the patient's steady state baseline hemoglobin level with a reticulocyte count of 378, normal renal function, normal fetal scan, and some deceleration on the CTG. So maybe just open it up to people who are listening on the call. What do people feel that this presentation could be due to, and what further investigations would you like to do?
Rick?
Sorry?
Sorry, can you hear me? No?
Yes, we can hear you. Yep.
Oh, it doesn't show on my thing. Well, she obviously excludes sepsis, first of all. Get an obstetric person in case they feel that she should be delivered. And probably try and get the hemoglobin S levels and and sort of advice about the beta thal side. The fact that she's got lupus is really unfortunate as well, and she'd be really high risk for everything. So you'd want to know what the rest of her white cell counts and platelets and things were doing. So
Yeah.
that's all I'm going to say.
No, thank you very much for that. And from a sickle point of view, what do you think could be the reason for such a dramatic drop in her hemoglobin?
Well, she's either hemolyzing or she's have we got any information on her liver and her spleen, whether she could be sequestrating?
Yeah. So that's, I think that's something that you'd want to do, definitely. If we go to the next slide. Yeah. So it could be a variety of different types of crises that are causing the drop in hemoglobin. Aplastic crisis would be not very likely in this case because the reticulocyte count is fairly good. So we're looking at either a kind of acute exacerbation of hemolysis or a sequestration crisis. And yes, as you said, you definitely want to do some kind of imaging of the liver and the spleen. But it's also important to remember non-sickle related causes, as you've highlighted as well, that could be contributing to the presentation. So it's important to kind of think outside of sickle cell disease as well. Yes, the patient should be transfused, obviously, but being cautious if this is sequestration, not to over-transfuse, as we discussed earlier. Thank you. We have the second case is a 36-year-old male with hemoglobin SS, frequent vaso-occlusive crises, bilateral AVN of the femoral heads, admitted with intense pain in the chest, legs, and back. And on initial assessment and examination, he's distressed, febrile, temperature of 38.5, tachycardic, respiratory rate of 22, and on pulse oximetry, oxygen saturation of 99% on high flow oxygen. You can see his blood work up there, hemoglobin of 96, slightly elevated white cell count, and bilirubin, LDH elevated, but we don't know what his baseline is. CRP of 19, chest X-ray showing cardiomegaly, and he started on a dimorphine PCA and broad spectrum antibiotics. 24 hours into the admission, he then develops, he desaturates and develops hypoxia with saturations of 82% on air, and CRP increases to 74.6, and the ABG shows a PO2 of 7.6, PCO2 of 6.6. So anyone want to comment on what they think is going on here?
So he's got acute, he could have acute chest syndrome, so he needs an urgent chest X-ray repeat because the CRP is very suspicious if the first chest X-ray only showed cardiomegaly and it didn't show, so his infiltrates might show up now, possibly. Yep. Obviously, he could still have infection, so you'd have to review the antibiotics. He could have a PE as well, so you'd probably think about getting an urgent CTPA.
Yep. Yeah, I think all those things are really excellent. And any comments on the fact that his we're told that his oxygen saturations were 99% when he came in, but the fact that he was on high flow oxygen, so maybe there were indications, there may have been indications of him being hypoxic initially if they'd measured it on room air. So that's just one of the things that I think this highlights, that we should be measuring on room air as well. And what do you think about the PCO2 being a bit high as well? I mean, that would be unusual in an acute chest syndrome. Does that raise suspicions of anything else that could be going on? So he's on a PCA, so there may be some
opiate
degree of
toxicity.
opioid, maybe some opioid toxicity. He's also got a large heart on the X-ray, so maybe some underlying pulmonary hypertension which hasn't been formally diagnosed. So yeah, could be some other things going on there as well. But the most worrying thing is obviously he's acutely hypoxic with raised inflammatory markers and fever. So I think consistent with an acute chest syndrome. Really, should go to the next slide just for some kind of tips and learning points. So yeah, I think really what we want to kind of highlight is that this is suggesting the patient has developed an acute chest syndrome, and the importance of monitoring as we said, the oxygen saturation is on room air to avoid a delay in diagnosis. And as you said, repeating the X-ray may now show some changes because the clinical signs often precede chest X-ray changes. So yes, and the indications for interventions with red cell exchange are usually based on the degree of hypoxia. So in this case, the patient has become significantly hypoxic and would almost certainly require a red cell exchange transfusion in this case, as well as discussion with ITU about NIV. And yes, not forgetting other causes of hypoxia, such as PE, pulmonary hypertension as well. Thank you very much. I think that was my last slide. Sorry to overrun a little bit.